So I'm really pleased to welcome you to the event. My name's Jane Brooks. I don't know if I said that. I am from the University of Manchester, and I am a member of the steering committee for the History of Nursing Forum of the RCN, and have been for several years. So I'm going to now introduce the three speakers. I'm literally just going to give you their names now, and then I will introduce them properly before each talk. So we have three very different speakers today, and I'm sure we're going to be absolutely fascinated with what they have to say. Our first speaker is Dr. Grace Redhead from the University College London. Our second is Dr. Lola Oni, OBE FRCN, who's a specialist nurse consultant. And our third is Gildé Nsianguana, who's a nurse and a sickle cell patient. So I'm now going to hand over without further ado to Dr. Grace Redhead, who is a historian and lecturer working on identity, citizenship and sickle cell anemia in the post-colonial National Health Service. Grace, you're very welcome, and thank you for joining us today.
So hi everybody, thanks so much for having me here. I'm really honoured to be on this panel with such wonderful speakers, and it's great to have such a huge audience for this topic. When we talk about, I'm going to first start by talking about the history of race in the National Health Service and the long historical context of race. And this paper is kind of based on a journal article that I published last year, which was based on my PhD research on the history of sickle cell in Britain. Next slide, please. So when we talk about sickle cell in the NHS, I want to start with the long historical context of race and the health service, and there are two key points to discuss here. Firstly, that the foundations of the welfare state and the NHS lie in empire and decolonisation. The welfare state was explicitly framed by William Beveridge, whose report kind of started the movement towards the NHS. As an institution that might guarantee the legacy of British ancestors such as the slave trader Francis Drake, and ensure the health of, to quote, the best of our breed. And Britain, once the health service was established, drew upon migrant labour to staff the NHS. So in 1968, Commonwealth migrants made up 30% of nurse pupil vacancies and 29% of student midwives. By 1975, 18% of GPs and 32% of those working in the hospital service were born outside Britain, and half of migrant doctors were born in the Indian subcontinent. And these were often the lowest paid, the lowest status and the most poorly paid roles, and really essential to the service. And then secondly, the second point is that since the establishment of the NHS, Black and Asian people and migrants to Britain have been excluded from notions of entitlement to the welfare state. From the beginning, there were tightening immigration laws in the second half of the 20th century that were justified by discourses around immigrant parasitism and like immigrants as an existential threat to the British health service. And in the racist discourse of the conservative politician Enoch Powell and his followers in the 60s and 70s, they framed the welfare state as a reward for white British people in return for their wartime sacrifice in World War II, which obviously ignored the war service of Commonwealth nations. So to kind of summarise, the National Health Service was originally thought of partly as a way of guaranteeing the health of a white imperial nation. And then after its foundation and after the beginning of decolonisation, it was staffed by migrant labour, and migrant labour was the foundation of the NHS. So sickle cell anemia is a sort of example of how this worked in practice in NHS medical space. The health system was not set up to prioritise the care of Black patients, but it was staffed by Black nurses who experienced racism and also witnessed racism being directed against their patients. Next slide, please. So the treatment of sickle cell in the post-war NHS kind of illustrates that the NHS viewed Black people and communities as social problems or as a minority rather than as citizens with medical needs. but that the NHS was also challenged from within on this, often by Black nurses, and from without by kind of advocacy groups. And that basically what was at stake was the status and entitlements of Black British citizenship. So sickle cell, as many of you know, is a blood disorder found more commonly in people descended from regions where malaria is or was common. So South Asia, the Mediterranean, Sub-Saharan Africa, Africa below North Africa, and it's been constructed as a disease affecting primarily Black people in British and American contexts. Next slide, please. So I'm going to talk about two flashpoints in the history of sickle cell in Britain. So the treatment of sickle cell crisis, particularly pain in hospital wards, and then debates over genetic screening in local and regional health authorities. And the examples I'm going to draw on from this are primarily from North London, but I want to stress that that this work was going on in other sort of centres in the UK as well. Next slide, please. So sickle cell crises, which are vaso-occlusive crises, are caused by blood cells getting hard and rigid, preventing their passage through veins, damaging tissue and organs, and disrupting flow and blood flow and bone marrow. And this is described as excruciating, and it's a serious medical emergency, which can lead to strokes and heart attacks. And in the 70s and 80s, medical understanding of sickle cell was really poor. A 1981 survey of nurses and health visitors in Brent and Kensington, Chelsea and Westminster showed that 72% of nurses and health visitors did not know sickle cell was not a form of cancer. Only 14% identified analgesics as a treatment for sickle cell. And in the accounts of people with sickle cell disease, sickle cell crises could be highly charged, really racialized, and fatal encounters sometimes. And the same kind of experiences would surface again and again. You know, someone would, after the onset of pain, someone would, try to treat it at home, would go to hospital, and then on arriving at A&E, they would wait to see a doctor, often for hours. Next slide, please. And so once they did see the doctor or nurse, things didn't necessarily improve. And so in one oral history interview that I did with a woman who was in her mid-60s, who I'm going to call Helen, she described her treatment in the 80s as a nightmare in which she was commanded to restrain her cries of pain and to control herself. She said, "They think you're an adult, you should be able to control it. That was the number one thing. You're an adult, you're in pain, you should be able to control it. Not that you've got sickle cell and it's uncontrollable. You can stop making that noise, there's no need to, it's not necessary. There's other people to consider, other patients on this ward. You're not the only patient. You've had a painkiller. If it hasn't worked, then you just want more painkillers." And this final sentence points to a really common experience described by patients in lots of the literature in the period, lots of the surveys now, and lots of the oral history interviews that I did. And that's the suspicion of the treating nurse or physician that the patient was a drug addict, faking or exaggerating their pain in order to gain access to opioids. And this suspicion could be applied to children as well as to adults. And this neglect could be really lethal. And there were multiple reported instances of people in crisis dying after long waiting times or being dismissed or ignored by doctors or nurses. Next slide, please. And so nurses could and did intervene in this. In 1976, the nurse Elizabeth Anyonwu described visiting a ward in North London and being told by another patient about a young girl who was being neglected by the nurses. And she said, "She was under the bedclothes quietly sobbing her heart out and had been in severe pain for many hours. Immediately calling a nurse, I made it clear I would not leave until she administered an analgesic." And healthcare professionals these healthcare professionals were drawing on on racism, but Black healthcare professionals, often nurses, would witness this dynamic between the patient and the doctor or nurse and could sometimes act as an intermediary in that dynamic or attend patients' bedsides to advocate for them. But the presence of Black nurses couldn't automatically guarantee protection for patients ward cultures were so dependent on the attitudes of senior nurses and doctors. And Lola Oni, who we'll hear from shortly, said, if you have a ward sister that believes that all sickle patients are junkies and a pain in the neck, you'll find that most of the staff will feel that way too, because they will want to be accepted by the ward sister. I couldn't understand why a lot of the staff were just so resistant to teaching, but when a particular ward sister left, the ward changed dramatically. So for an emerging group of specialist sickle cell nurses, a key aspect of their work was the legitimization of sickle cell pain, crisis pain, through educating doctors and nurses. Next slide, please. And these specialist nurses were joined in this work by voluntary organisations, such as the Organisation for Sickle Cell Anemia Research, which was OSCAR, and the Sickle Cell Society. And such organisations enabled healthcare professionals and patients to work together, and also provided a mouthpiece, sometimes for nurses and health visitors, like Lola Oni and others, to kind of advocate outside of their NHS roles. Next slide, please. So moving on to the second half of the talk, the primary intervention considered for genetic conditions in the 70s and 80s was genetic screening, and neonatal screening in particular was identified in 1973 as really important to pick up babies with sickle cell early and start treatment early. In the 70s and 80s, nurses and doctors interested in sickle cell petitioned local and regional health authorities to pilot screening services, and they were challenged by two main objections. Firstly, that the local areas were not diverse enough for the intervention to be cost effective. And secondly, that Black families were not suitable for screening for social and cultural reasons. And I'm going to go through an example of each. So next slide, please. For example, for one, a 1971 to 75 survey of live births in London boroughs had shown that in Brent, this is on the left, 38% of live births were born to mothers from the new Commonwealth and Pakistan, the highest in England and Wales. It was the most diverse area in England and Wales at the time. In 1981, a local haematologist called Milica Brozovic asked the North West Thames Regional Health Authority, which covered Brent, for funds in order to do a screening programme. And she recalled that the authority refused, and the authority said, we do not have that many people from ethnic minorities. It is not cost effective to do it. And this is in the most diverse place in England. In response, Brozovic and her colleague Elizabeth Anyonwu focused on proving that they did indeed have that many, that we had more than Tay-Sachs, more than Down syndrome, and they undertook a pilot screening programme at Central Middlesex Maternity Unit. The estimated cost was £20,000, which the authority would not pay for. So Brozovic conducted the survey out of their existing budget, remembering that they had to squeeze here and squeeze there, but it was a really hard battle. And they, having done this, they used the Brent Sickle Cell Centre as their base for this. And by 1985, they'd picked up 193 recorded cases of sickle cell disease in the borough. And this increased to 300 cases by 1987 and to over 400 cases by 1993. So despite what the Regional Health Authority said, the need was clearly there. Next slide, please. And then where boroughs did acknowledge they had a large at-risk population, the health authorities would push back by arguing that Black families were not suitable for genetic screening. And Elizabeth Anyonwu met with Camden and Islington Health Authority to discuss extending sickle cell screening, not just to pregnant women, but also to their partners, to the father. And she said that the attitude of the officials that she met was, to quote, the Black community were not educated enough to understand genetics, and the high number of single Black mothers would make it difficult to screen partners. Elizabeth said there was an insinuation that this group was promiscuous and lacked stable relationships because they were married. And partner screening did exist in this borough for Thalassaemia, another haemoglobin disorder that had become associated with South Asian and Cypriot communities in London. And this was not an isolated incident and was a consistent reason for pilot screening programs to be pushed back. And Manchester's pilot screening program in 1976 did not test fathers because they said that the mothers were not married. And this was something that nurses and doctors who were interested in sickle cell tried to push back on. Next slide, please. Specialist health workers also applied pressure on health authorities through surveys like this one, Sickle Cell Anemia, Who Cares?, which was undertaken through the Runnymede Trust. And in this, they noted that many areas with a real need for this service, such as Wandsworth, did not have screening or counselling services. And it's worth making clear that the battle for screening programmes was about more than diagnosing babies born with sickle cell, though that was really important in order to treat them. It was also about generating a body of evidence that sickle cell disease did exist in the British communities, and to justify services for people with sickle cell. Because without those numbers, in the words of the head of the Runnymede Trust, Usha Shah, the absence of statistics is in turn taken to represent the absence of individuals affected, and then used as an excuse for the failure to provide suitable facilities for screening and counselling. Next slide, please. So from this case study of this debate about screening, we can see that the local health authorities constructed people with sickle cell trait and the full disorder, were constructing them as a geographical, cultural and social minority, and trying to make the case that in these ways they were not somehow eligible for NHS care. But local healthcare professionals, made up of nurses, health visitors, haematologists, worked within their budgets, sometimes on a voluntary basis, to run these pilot screening programs and to prove that the need was there. And these pilot programs became the basis for the National Sickle Cell and Thalassaemia Screening Program. And once this program was introduced in 2005, it led to a big uptick in the number of children identified with sickle cell disorder. In some cases, the numbers actually doubled, and a review of the national program suggested that the previous underdiagnosis had probably led to some children dying undiagnosed from sickle cell disorder. Next slide, please. So to conclude, I started this talk by saying that the NHS had this paradoxical relationship with the Black British people that it was supposed to serve. It was dependent on their labour, but the NHS itself was also tacitly set up to view Black health as a minority issue, which it was not cost effective to address. And Suzanne Scaife, Stella Dadsey and Beverly Bryan, in the book on the left, Black Women's Lives in Britain, called the NHS the uncaring arm of the state, arguing that it was an institution which saw Black people and Black women as workers for, but not consumers of, the health service. And then in 1993, in a Sickle Cell Society newsletter, the footballer Garth Crooks, who's in the picture on the right, said, "Sickle cell is a British problem affecting British people." And so what was at stake was, in these discussions over sickle cell, was the big question of whether Black health was British health, and Black Britons were often excluded from the notion of British citizenship, and so their status of health citizenship and their entitlement to health services was also challenged. But welfare state actors, many of them Black nurses, worked within NHS institutions to make sickle cell disease visible as a health condition in Britain, and they pushed for safe treatment for the illness on hospital wards and demonstrated the scale of need through screening and surveys. So by making sickle cell a visible public health issue, and by compelling the state to see the people that they were charged to care for, these nurses and doctors and volunteers and people with sickle cell invoked their citizenship and presented an alternative vision for the welfare state going forward. Thank you.
Thank you very much, Grace. That was fascinating, and I'm sure everybody has learned much and felt very disheartened by the early years, and hopefully things are changing. So without further ado, we're going to move to our second speaker, and we're very honoured this evening to have Dr. Lola Oni, OBE and FRCN, to talk to us on the subject of sickle cell services in the UK from 1979. Lola is a specialist nurse consultant and lecturer and former director of the Brent Sickle Cell and Thalassaemia Centre. So welcome, Lola, and thank you for joining us this evening and giving us the benefit of your wisdom.
Thank you. Thanks for inviting me to speak. Can you see my screen?
Yes.
Can you see my slides?
Yeah. Yes, okay, I can, Lola.
Lovely. Thank you. Thanks very much for inviting me. It's a difficult act to follow after Grace. And I'm not sure that I won't be repeating a little bit of some of the things that, that Grace has said, but I don't think that matters too much. So really, I'm just going to talk about how the services have developed over the years, as Grace has already mentioned one or two key points within the development of sickle services. I'd like to make my acknowledgements at the very beginning to thank all those who've contributed to the development of the specialist field in the UK and globally, and to all those who have taught me, and particularly my patients, because my patients were my biggest tutors to teach me about sickle cell and what it's like to live with it. All my students from when I was lecturing, and I'm still lecturing at the university, and of course my long-suffering family for putting up with me and only ever talking about sickle cell and anaemia. I think before we can understand how we got to where we are now, we need to really understand the history of Black people's presence in the UK. And some people in the audience today will probably have heard some of this lecture. And if so, I make no apologies, but it'll just be a refresher for you. But we have to understand that the Black presence in the UK is what has impacted on the development of sickle cell services in the UK. I particularly like this, this publication. It's a history of the Black presence in London that was written by the Greater London Council in 1987. This documentation, it tells us that Black people's presence had been around, documented since the 3rd century AD, when there was an African division of soldiers defending Hadrian's Wall. Also, we have reports of a trumpeter that was employed by courts of Henry VII and Henry VIII. And this Black trumpeter rode in Westminster Tournament when the birth of son of Catherine of Aragon was being celebrated. So all these things were happening, long before NHS, was born. By mid-1600, British colonies have evolved quite a lot. You found a lot of the West Indies and South America, sugar plantations, cotton, tobacco, and there was an increasing need for manpower. So the majority of Black and Asians in London pre-19th century, although they were single men, they were quite useful. A lot of these men, obviously intermarried with the indigenous population, but they were being transported to the West Indies and South America to go and work, usually as overseers and what have you. You started to see a decline in the population in London and in the UK. By 1771, 190 British ships transported 47,000 slaves to plantations in West Indies, South and North America. And as I said earlier on, many of the Blacks that were in the UK went to work as low-ranking managers and overseers in the sugar plantations and so forth. So by the 19th century, the large Black community of the century before seemed to have disappeared. So people actually forgot that there were quite a lot of Black people in the UK even before World War II. Post World War II now, from 1945 onwards, there was, of course, a shortage of labor, which led to the invitation of people from the British colonies. And I think Grace has already mentioned this. So you had a large proportion of people being invited, and we all know of the famous SS Empire Windrush, 1948 to about 1962. By that time, over 98,000 Jamaicans had migrated to the UK to come and work in the new emerging health service, to come and work on the buses, in the underground, on all the areas that, that it was difficult to get laborers and workers. And you had a lot of students also coming from the colonies, both India, Africa, Asia, and all the other parts of the world. So you had a significant migration from post-World War II. Of course, it's highly unlikely that if you are somebody who experiences illness and have a lot of pain, your family wouldn't encourage you to go abroad, particularly to a cold country like Britain. So one can assume that majority of those who traveled to the UK would be those who were healthy carriers and those who maybe had milder forms of sickle cell disease. By 1950 onwards, the number of children with sickle cell disease that were being born started to increase because evidently, as your carrier couples started to marry and they started to have children, and these children were being born with sickle cell disease. And a lot of medical textbooks used to talk about a rare tropical disease that's seen in Negroes and rarely seen in the West. There was a lack of awareness among those at risk, lack of knowledge among health and allied professionals, not to mention lack of knowledge generally in the whole community. People didn't even know much about it. But the problem with the lack of knowledge was there was an increasing number of deaths in young Black children and in the youth. So what was the catalyst for the development of specialist services? In those early days, there was often a misdiagnosis of Black children when they were experiencing sickle cell as a result of dactylitis, which is what we call hand-foot syndrome. And parents were often accused of child abuse because people didn't know, the healthcare professionals didn't know what the condition was, or they didn't know how to diagnose it. And so parents were often accused of child abuse. By this stage, concerns were being expressed by health and allied professionals. The number of children that were dying, the number of children and youths that were experiencing pain and suffering. There was a community outcry. And that saw the birth of OSCA in 1974, that's Organization for Sickle Cell Anemia Research. And the main focus at that time was research, not care or, managing health services, but we want to do research to find a cure for this condition. But quickly after that, by 1979, it became quite evident that finding a cure is not the only thing we should focus on. We need to find a way of supporting individuals with this condition. And so questions were raised in local authorities, in mainstream media, people like Trevor Phillips and all sorts of other presenters, celebrities lent their support. We're talking about why is it that all these Black children were dying? Why is it that healthcare professionals didn't know about this? Why is it that the Black community themselves didn't know an awful lot about this? And so you saw the development of community specialist centers in the UK. That was a landmark. The first specialist sickle cell center, and note, the center was actually named Sickle Cell Center in those days. They became sickle cell and thalassemia centers a few years later when it became evident that thalassemia and sickle have some similarities, and they were both managed by hematologists. And therefore, it was a good marriage to have sickle cell and thalassemia managed by the same units. So the specialist center was developed, the very first one in 1979, by Dr. Misha Brozovic, and now Dame Elizabeth Anyon. Sadly, Misha Brozovic passed away last year. And this was established in Central Middlesex Hospital through the efforts of parents, the voluntary organizations, and other healthcare and allied professionals. So what was the objective of these specialist centers? It's to enable community awareness, to promote education of professionals, to encourage access to appropriate testing and counseling, and to enable those at risk to make informed genetic choices and access healthcare. But very importantly is to educate and support individuals with their condition and their families. Those were the main reasons why these specialist centers were developed and established, and to promote screening and awareness. This slide gives you an idea of the number of sickle cell and thalassemia community specialist centers as we have it now, dating back to only 1998. And we've seen the emergence of not only the community specialist nurses, which were all we had when we first came into the specialist field, but you've now seen an emergence of clinical nurse specialists who work in the hospital, looking after patients with sickle cell disease. And then you've seen the involvement of specialist midwives also who are there to support people who are at risk, those who are identified when they've been screened, and also to enable partners to be tested so that parents can make an informed choice. But you'll note from this slide that there's a gradual declining of the number of specialist centres in the UK. And this is a worrying trend. If you notice that London has always had quite a significant proportion, evidently major cities in England have the highest proportion of minority ethnic populations, and therefore they're more likely to have a larger proportion of centres. But we're seeing a gradual decline in the number of community nurse specialists that are being employed, because preventive care is not seen as important as acute care, and that's a worrying trend. We're seeing an acute clinical nurse specialist increase in numbers, which is a good thing, and we're seeing specialist midwives, and now we're seeing specialist nurses, CNS antenatal screening coordinator roles starting to emerge. So the landscape is changing and changing quite significantly. But the worrying trend for me is the gradual decline of community nurse specialists over the years. We know that there are approximately 240,000 people that are carriers with sickle cell disease, and those with sickle cell disease are approximately 15,000 in the UK. This gives you an idea of what hemoglobinopathy specialist nurses, clinical nurse specialists, and midwives do. Apart from policy development, they're involved with preconception testing and counseling, they're raising public awareness, they're educating, they're managing antenatal and newborn screening, because all babies in England are offered testing for sickle cell disease as part of their blood spot screening. Education, community and social welfare support, clinical management, publication, advocacy, research and development. So the role of community specialist nurses and acute care CNSs, etc., is quite vast. There have been a number of publications over the years relating to sickle cell and thalassaemia. A lot of these have come out as a result or as a response, often to issues that have arisen within the management or the care provision for people with sickle cell disease. We have a number of clinical standards. The most they've been updated. The children's standard was updated in 2019. The adult standard was updated in 2018. And these standards give you a hallmark of what it is you're supposed to do to look after people with sickle cell disease. It's very clear what the recommendations are. It's very clear the level of care that's expected to be given to people with sickle cell disease. These two volumes is what I call the Bible of provision of care for people with sickle cell disease in the UK. It's interesting that sickle cell anemia was the first genetic disease to be defined at the molecular level, and its study serves as a model for the application of modern molecular genetic analysis to clinical disease. And yet, in terms of research, it's been minimal development in the field of sickle cell disease. In 2018, I led a group that looked at the education of nurses and midwives about sickle cell and thalassaemia. And we did a report, the all-party parliamentary group published the report, which we presented in the House of Commons in 2018. And within this, we saw quite clearly that there's very poor provision in the nurse education and midwives education in relation to sickle cell disease. And this is very, very concerning. And we've raised this with Health Education in England as to how we can ensure that sickle cell is covered in the nursing and midwifery curriculum. Qualified nurses, doctors, and other healthcare professionals lack knowledge of sickle cell and thalassaemia, and it affects their ability to provide skilled and effective care for those with and at risk of these lifelong genetic, chronic, and potentially fatal conditions. So if you don't provide training, if you don't provide education, how do you expect individuals to be able to care effectively for people with these conditions. I'm sure many of you will be aware of the death of Evan Nathan Smith, a 21-year-old who died in 2019 whilst he was in hospital. But what was most concerning is him having to dial 999 while he was still in hospital, in a hallway in a hospital, because he could not get the treatment that he needed, because staff did not understand sickle cell disease. Similarly, the death of another patient was reported in sickle cell sufferer died due to neglect, was the coroner's verdict. This was reported in Brent and Kilburn Times. These are not uncommon cases. We've known over the years how many patients have suffered as a result of not getting effective care or appropriate care. The APPG wrote a report recently as well, the Sickle Cell Society, in 2021, called No One's Listening. You can get all these reports and all these documents on the Sickle Cell Society website. And it's called No One's Listening, and it's an inquiry into the avoidable deaths and failures of care for sickle cell patients in secondary care. And this is very concerning when we've got national standards. Why would patients still not be able to get appropriate care? The key findings from the inquiry include evidence of substandard care for sickle cell patients, substandard care on the general wards, as well as those attending A&E. Widespread lack of adherence to national care standards. A low awareness of sickle cell among healthcare professionals, and clear examples of inadequate training and insufficient investment in sickle cell care. But the one that concerns me the most is the frequent reports of negative attitudes towards sickle cell patients. And the weight of evidence suggests that such attitudes are often underpinned by racism. The inquiry also found that these concerns have led to fear and avoidance of hospitals for many people living with sickle. These are worrying. We've come a long way in terms of provision of care. We've written reports, we've written standards, we're teaching, we're educating as much as we can. So why is attitudes not changing? Sickle cell patients don't want to have their lives interrupted by hospital admissions. So bolstering our community services and listening to patient and clinician groups to focus on what keeps our patients well at school, at home, and at work, and what's supporting the community will allow them to stay well, will allow them not to have repeated hospital admissions. The common theme in a lot of the inquiries following the death of Evan and other patients is a lack of knowledge amongst healthcare professionals, poor communication between professionals and between patients and their caregivers, a lack of empathy, a negative attitude to the patient group. And this is very, very worrying. NHS Blood and Transplant stated knowledge and awareness of sickle for all levels of staff within emergency department in particular should be mandatory inclusion, as it is with other comparable serious and chronic illnesses. The fact that sickle cell disease only affects a minority of the population is irrelevant, as the illness still remains the biggest inherited single gene disorder in the UK, and therefore warrants a higher level of awareness than currently exists. It would appear that making training mandatory will be the only effective way to correct this oversight. So, what does the future hold in providing sickle cell services and care? In 2018, NHS England developed a strategy to improve specialist hemoglobinopathy services in England. And therefore, they developed a strategy whereby you have local hemoglobinopathy teams, giving general care, but then you have specialist hemoglobinopathy teams and centers, which are funded to undertake specialist clinical activity. But the most important and very, very important area of development is the development of hemoglobinopathy coordinating centers, HCCs, for sickle cell and thalassaemia, and a national hemoglobinopathy panel. These developments is going to create and enable better coordination of services, having oversight of services, and ensuring that providers remain accountable for the provision of care that they give to people with sickle cell disease. And this map gives you an idea or gives you an outline of the 10 the coordinating centers in England, where they're located in England. And the National Hemoglobinopathy Panel, of which there's only one, which has been managed by King's College Hospital NHS Foundation Trust. What does this mean for patients, this development? It means patients in what we call local hemoglobinopathy teams will need to be seen by an SHT annually for routine monitoring and specialist care planning. There'll be better management of the process and approval for specialist and novel treatments. There'll be better coordination of local, regional, and national activity and data collection through KPIs or dashboard. Staffing will be scrutinized at all levels. So this for me says there's hope. This for me says the route in which the NHS is taking this is the right route. But we need to address the issue of attitudes. Here's a picture of the 40th anniversary of the first centre in the UK in 2019. But we've seen a decline, a rapid decline in number of specialist centres. What does the future hold for our patients with sickle cell disease if we don't have the community support, or we don't have the appropriate acute care, if we don't have education of health and allied professionals to ensure that people understand how to look after this patient group effectively and appropriately? So what next? Who'll be accountable in shaping the future? Well, it'll be those of us who are still practicing, those of us who are still looking after this patient group. And that doesn't mean specialist nurses and doctors. It means every single one of us that have contact with this patient group, irrespective of which area we work in, whether it's A&E, whether it's the general ward, whether it's the community, whether we work in the lab, whatever it is, wherever we work in the health service, we are accountable in helping to shape the future. Thank you.
Thank you, Lola. That was a tour de force. And I think many of us have learnt so much from your talk, things that we really didn't know and that actually are, as you really quite shocking. And we all hope that things do continue to improve as you are so positive about, which is good. So we now move to our very final talk of the evening. Gildé Nsianguana is a nurse and sickle cell patient and presenter of the BBC documentary Sickle Cell Fighting for Care. You are very, very welcome, Gildé, and we look forward to hearing your very personal story. Thank you.
Hi, so I just wanted to start off by saying hi and thank you for inviting me to this talk. I'm really excited to be here along with the other panelists, and just wanted to also start off by saying that I am actually in hospital. So if I go quiet for a second, it's probably because the doctor's walked in, because I am expecting someone to come in and talk to me, hopefully. And it's just unfortunate that I've landed in hospital, but it is literally the reality of a sickle cell patient. I don't know when I'm going to be in, and to be honest, I don't know when I'm going to go out. But yeah, just wanted to start off by talking a little bit about my personal story first. And just even listening to both of the presentations before, it was just a bit really sad to see how a lot of things haven't really changed as much in terms of like attitudes over the years. But start off with me. I am 27 and I am a pediatric nurse. Um, my sickle cell journey has been pretty tough, I would say now. Um, when I was a child, I used to be in hospital quite a bit, but I don't really remember too much of it. I just remember being in hospital, missing out on like school trips in primary school, and missing out on like few fun days, for example. And I just remember being sad about it. I don't remember too much about it. I didn't really know what sickle cell was either. I just knew that I had something that was wrong with me that caused me pain. But that was as far as it went, really. As I got older into secondary school years, I was in and out of hospital, but not so much. And then towards the end of secondary school to sixth form and university, um, by the grace of God, I actually had about a good 6 years where I didn't even go into hospital, which was great for me. Um, but it also meant that I didn't really know much about sickle cell either, because I just kind of put it to the back of my mind. It was only in uni where I was separated from my family that I realized that I had to start talking about it, especially because I went further away from home. So I studied in the University of York and I live in Essex. So it was quite far away. Um, and I was on my own. I didn't have my twin with me, so I'm a twin as well, and she usually cares for me as well. Um, but I went all on my own, so I realized that I actually had to start learning about the condition that I have, and that I need to start telling people around me just in case something happened, like my roommates. Um, and that's when I became a little bit more confident in talking about sickle cell. Um, so I went through uni. um, Sometimes I was in pain, sometimes I wasn't. I do remember studying really hard, being in a crisis, but I just kept going because I really wanted to graduate and finish my nursing degree. But it wasn't until I left uni and came back home where my health deteriorated and it went slowly downhill, I would say. So the first few years, I had more crisis in a year. I went from having about 1, 2 crises in a year where I'd end up in hospital to having about 4 or 5 a year. Um, People would ask me if it was work, because that's when I started working full time, and if it was the stress from work. But honestly, I didn't feel stressed working. Nursing is something that I've always wanted to do just because I was in a hospital a lot as a child. I always looked up to my nurses, and I just remember being so fascinated by what they did. And I remember this really nice male nurse who looked after me, and I just kept thinking, I want to be like him and look after other little kids and just give them the best possible experience in hospital. So I've always wanted to do nursing. I finally became a children nurse. So I didn't find it as stressful as other people probably thought, but my body was saying otherwise. I ended up in hospital, and then I ended up going through different treatments, from starting tablet called hydroxyurea, which that didn't really help me so much. So then I went on to the blood exchange program, which I still am on. So I have to have blood exchanges, which is a bit similar to a blood transfusion, but a blood transfusion is more of a top up of blood, whereas an exchange is where you take out your old blood and put in new blood in at the same time through this amazing machine. And then I do that every 4 weeks now, and I get 6 units of blood. Um, and that's my treatment so far. And it was going okay. But then the pandemic happened, and my sickle cell changed on me as well again. And I went from just dealing with normal sickle cell crisis, which is an episode of pain, which would come every now and again and last about a week or two, to dealing with chronic pain now. And this was a result of my sickle cell. So it is, in simple terms, sickle cell over the years has damaged some blood vessels and muscles and tissues in my back. Where they haven't had enough oxygen, they've sort of died off. And now this causes me terrible pain. And it only started during the pandemic. And I truly believe it's because I went from working 12-hour shifts all the time to doing completely nothing, where we had to shield. Sickle cell patients are considered extremely vulnerable. So we had to shield during all of the different times where the government told us we had to stay at home. So the first one was 3 months, and then we had another few lockdowns as well where we had to stay at home. And then this flared up a really bad back pain, where now it's become kind of uncontrollable, and no one really knows how to treat it, because treating chronic pain is pretty complex. And it's got to the point where I feel no one really knows what to do with my pain. So now I have been in hospital for nearly like a few weeks, but I'm usually in hospital for months on end, like a couple months here. I'll come out for a few weeks and then I'll go back in for another month or so, just because of the chronic pain. I'm on a lot of opioids for it, and a lot of nerve pain medication, just lots of different types of medications, trying to figure out what's the best that works for me. And I'm involved with lots of different teams, for example, the pain team, physio, and my normal consultants. But that is really what is happening with me. And yeah, so my sickle cell, I would say, has become pretty debilitating now. I've not been able to go to work. I was in hospital on my birthday. I've just not, some days I'm not even able to get up out of bed. Like, the pain is that much where I can't do anything anymore, which is just really sad. It's broken down friendships and relationships because I'm always in hospital and people's lives go on. Um, and I'm not really sure what to do anymore. The doctors are not really sure what to do anymore. But being in hospital, as well as being a nurse as well, has shown me a lot. Like, just seeing the way nurses treat sickle cell patients, especially as I've been in a few different hospitals, just the way our care is surrounded, is pretty poor, which is very unfortunate. Like, I've argued with doctors, I've argued with nurses, just for pain relief. Like, pain relief is a big thing for us, especially with my back pain as well. Opioids are needed. And I've had to argue with doctors where they've told me that I don't need any opioids, or I don't need certain things. And I've had to physically argue with them just to get some sort of pain relief, because I'm in so much pain. And whereas I'm not screaming and crying, a lot of people think that you're not in pain. Like, sickle cell is an invisible condition, and the majority of us look perfectly fine. Like, I can be in A&E on my phone where I'm trying to distract myself from the pain, but they would look at us in A&E, see that we're on our phone, see that we're fine, we're quiet, and think we're not in pain, and they'll just leave us. Like, I've been ignored, everything. Like, you have to physically cry and scream to be heard. Just like that report, no one is listening to us. Um, Even just the other day in hospital, I had a nurse that came in from another ward that was looking after me. And she asked me what my pain score was. I said my pain is a 10 because we were changing different medications and my pain was not controlled, and it was a 10. She said to me, your pain cannot be a 10 because you're not screaming and crying. To me, that is like one of the worst things you can say to me, because I've dealt with this pain for 2 years now. And I know that I can't be screaming and crying because that will make my pain worse. I know that I have to try and hold myself together in order to get through and distract myself. So you telling me and judging me because I'm not crying, that I'm not in pain, like I just couldn't believe it. I asked her to get me the doctor and my nurse in charge multiple occasions, and she didn't do it because she just didn't believe me, which was crazy to me. Even when the doctor did finally arrive, which was 5 hours later of me being in pain, rolling around in bed, and I was crying, she just didn't see it. 5 hours later, the doctor arrives and they said that they didn't come to me because I wasn't on the verge of death. I felt like I was on the verge of death, and they would have known that if they just popped their head in for 2 minutes just to talk to me, which I asked for because all I needed was pain relief. But they didn't care and no one wanted to listen to me. And it's just stuff like that. It's very sad. I've heard multiples of things regarding sickle cell patients where staff members get annoyed when they're looking after sickle cell patients. They ask to swap patients. They sometimes it's not even um, what they say. It's the non-verbal communication, the tuttings and the sighings and the rolling of the eyes. And you can ask for pain relief as well, and they're like, didn't you just have any? And it's like, yes, I did, but it's not worked. Honestly, I feel like sometimes they think that I'm in hospital just to get pain relief. People look down on you and they're looking at you during handovers and stuff like that when I'm talking to them about my pain. And they're like, you need to stop taking this. And I've always said from the beginning that I didn't want to take all these opiates for my pain, but that's the only thing that they're giving to me. So now that I've started taking a lot, they're like, you have to stop, you can't take it. And they're looking at me like I am a drug addict, which is really sad. Like you can just tell the way people look at you, and it is really sad. And sometimes I do cry to myself because I don't know what to do. The doctors are looking at me like I want to be here taking this medication all the time instead of being out and about, which is so wrong. I want to be out, back at work, living my life. But unfortunately, I can't be because my pain is that bad. Like, it is really sad. And it's not just me that have said these things. I talk to multiple sickle cell patients because I have a online platform where I reach out to people, people reach out to me, and they say the same thing. They've heard nurses outright say, oh gosh, this patient's back again for drugs, or he's just a drug seeker, or something like that. Just wanted to round off though by saying that there are um, a lot of good nurses as well within the NHS that do really do look after me and look after me to the best that they can. And it's just really sad that the nurses that don't, or the ones that I just feel like have not looked after me to the best, like they let the good ones down, which is just unfortunate. And I do feel like there is still a big gap to fill where a lot of nurses just need to understand what sickle cell is. Like, it was World Sickle Cell Day the other day, and this was the day where I had a nurse that didn't even understand what sickle cell was when they were looking after me. And it just made me really, really upset, honestly. And I just feel like with the amount of education and awareness that us patients put out there, there should be some sort of change, and I'm just hoping that there will be one day. Like, it's just unfortunate as well that patients, while we're in pain, we have to be screaming and shouting and trying to argue with health professionals just to get good care because we're being denied of certain things. And it's just really, really unfortunate. And that's also what I learned throughout my BBC documentary, like listening to Evan's parents and his story and stuff like that. It was just so sad because stuff like that is real, and it's happened to me where I've been denied of certain things, and it's just horrible because you can envision something as bad as that happening to you, and it's just really, really sad. But I do
Thank you.
really hope that there will be a change. I'm just not sure as to when, because the attitude of nurses and other health professionals is so, so hard to change. And they've already got it really like stuck in their ways of like what they perceive sickle cell patients to be, like as difficult patients and complex patients and hard, and were mean and nasty and drug addicts. And it's just hard to change that perspective.